Dear Edudent friends and colleagues, I trust you are most probably all of you back to work, like we are in Switzerland, still with some restrictions in terms of the procedures we can perform, or eventually the environment that we have to organize in order to receive and treat safely patients, and also to maintain safe environment for our staff. That has been actually a quite a disrupting period again, the second one after the COVID lockdown. And this is why I somehow put the dental e-talk on standby, because I thought that it might be maybe not opportune to disturb your concentration, return and to return to work and reorganize your dental practice. But I think now it is time. It is time to communicate again, and I'm pleased today to discuss with you an interesting topic, which is the crack tooth syndrome. And this will happen before some more topics will be published on the Edudent International webpage. I really plan to have a few more dental e-talks, maybe together with a little bit more comprehensive programs, online programs, which are accessible to each of you, your friends, yourself, if you want to see what is new at the Edudent Education Center and what we offer in terms of programs. I wish you an interesting moment to spend with me, and I look very much forward to our next e-talk. Enjoy the moment.
So let's start this dental talk. The crack tooth syndrome actually is one of the two critical biomechanical conditions which we can face. The crack and the non-vital tooth situation, which I will discuss in another dental talk. We have different type of cracks. We have very superficial ones like craze lines. We have lateral cracks, fractured cusps, and we have central cracks, which of course can be more or less severe depending how deep they extend into the tooth. And we have split tooth and vertical root fractures, which normally have a rather negative outcome or very critical outcome. The vertical root fracture actually being treated logically with an extraction, and that is something that we wish by any means to avoid. You see here an example of craze lines. Those craze lines are infiltrated by the biofilm, but usually as it stops at the dentine enamel junction, it does not provoke any particular symptoms. See here a clinical image of a patient who consulted because of mild pain under pressure. X-rays usually don't show anything special. There is no recurrent decay, but you might, of course, observe here some external cracks. It actually is rather difficult to know exactly the extension of cracks until you have taken the amalgam away or the old restoration away. And now you start to understand why the patient might experience some discomfort and pain under pressure. This observation is typical from the modern generation of amalgams, high copper amalgams, which mercurial expansion on the setting was really far too high, and that has provoked basically this kind of crack basically around and underneath every single amalgam that has been placed during a couple of decades. There is another crack tooth syndrome with very severe pain in this specific case. We had a composite restoration, not made by myself, but placed a couple of years ago. We can assume to replace an amalgam. And when we open the restoration, we maintain the mesial and the distal walls, which normally do not disturb to make a diagnosis. And we could witness actually a central crack, which is unfortunately the most critical crack. Unfortunately, after an attempt to calm the symptoms with anti-inflammatory cement, which is the leather mixed cement, that product, by the way, is getting slowly withdrawn from the market, unfortunately, despite its incredible efficacy to reduce that kind of symptom. So we had to start endodontic treatment. And you see that actually the crack is extending much deeper into the root. So when we informed the patient about this finding, we explained also the risk of having to extract the tooth later on, even though we try to proceed with a very conservative approach. And in fact, the patient refused any risk to be taken, and finally the tooth was extracted upon decision of the patient. Just to explain that this kind of central crack is the most disturbing one. It is interesting to see which are the statistics and risk factors associated to cracked teeth. And in this study from a very active group in Korea, in Seoul, at the University of Seoul, they have here summarized their results. And you see that intracoronal non-adhesive restorations show the highest rate of cracked. In regard to adhesive restorations, you see that composite, even though better than amalgams and gold inlays, still present a much higher risk factor than ceramics. And we'll come back to this finding a little bit later. Another very interesting finding, again from the same group in Korea, is that nearly 30% of intact teeth also show or might show a cracked tooth syndrome. So it's interesting to know which are the reasons for that. For restored teeth, there are a lot of different conditions related to depth, dimensions of the restoration. Also occlusal factors, logically, we have more risks in patients with bruxism and clenching. Could be also related to masticatory accidents or any abnormal trauma. But what is interesting to know is that some teeth present incomplete fusion of calcification areas, which in fact trigger eventually mesodistal cracks in non-restored teeth. To be honest, I haven't seen any histology that is described in the literature, but that might account for a relatively high rate of mesodistal cracks in upper premolars, for instance, and some. How do we diagnose a cracked tooth? Usually, it starts with pain. It can be just observed clinically, but the reason for a patient eventually to consult will be either sharp pain on biting or chewing on a particular tooth or particular area of the tooth. Sometimes with a rebound pain, when you release the pressure, then the pain is even increasing. And there are also some hyper reactivity to hot and sugary stimuli. And that might be triggered by different fibers, as we will explain a little bit later. What is common normally to cracked teeth is a positive response to vitality tests. What this very classical study from Rikuchi has shown is that any crack, superficial as deep one, is being infiltrated by the biofilm. And in fact, cracks are highways for bacteria or bacteria's byproducts to penetrate deeper into the tooth structure. And it's not surprising that the medial-distal crack is the most critical one, because it brings the bacteria to penetrate all the way to the pulp when it is not treated in due time. The way you can have an idea about the severity and the prognosis of the crack is the kind of pain that will be created under pressure or thermal stimuli. If you have a stimulation of delta nerve fibers, you will trigger a very sharp and very short pain. That is actually the fibers within the dentin. But that is a mechanical stimulation, contrarily to stimulation of C fibers, which are basically demonstrating pulp inflammation. So here in this case, you have a dull, poorly localized edge, and it goes up and then it takes a lot more time to return to normal. So the pain will be more durable. And sometimes you have both pains being basically happening at the same time. You might have the sharp sudden pain under pressure when you basically deform the tooth, or you allow the crack to be deformed. And at the same time, you have the C fiber stimulation in conjunction with thermal stimuli. That might, of course, make the prognosis discussion a little bit more difficult. But anyway, we will discuss which are the different options to treat. The treatment objectives at the end are very simple. First, you want to stabilize the tooth structure, prevent deformation and mechanical stimuli to be reduced, if possible, let's say suppressed completely. The second treatment aim is, of course, to block bacterial infiltration. We need to seal those cracks from everywhere we can, either from the outside and the inside, for sure the inside of the cavity, but also sometimes from the outside. So we can reduce the pain and symptoms and preserve the structure and the tooth. Basically, for the medial-distal crack tooth syndrome, our objective is to be able to avoid endodontic treatment, possibly further in time, vertical root fracture and extraction of the tooth. And that's, of course, a very critical situation. In other words, we don't want to fail on that very specific situation. From a clinical perspective, there are two clinical scenarios. First are lateral cracks or proximal cracks, which actually will not drive the bacteria to the pulp. Those cracks are normally those stimulating delta fibers, those which create sharp sudden pain but are less likely to produce this dull, long-lasting pain which we have when the pulp is inflamed and when the C fibers are being stimulated. We also have those proximal cracks, like the lateral cracks. We normally use very conservative technique, and normally for such a situation, composite is absolutely a feasible solution. And after having treated hundreds and hundreds of those cases, I can at least speak from my own clinical experience and also from the literature, which is supporting these findings, is that using composite is highly successful. Here, a clinical case, again, a patient complaining about pain under pressure on that specific tooth. We have no recurrent decay. We can only observe that crack here extending relatively far towards the cervical part of the tooth. And after opening up the cavity, taking the amalgam away, you see actually that there is a crack going all around basically this occlusal amalgam. Again, this is the very common finding underneath and around high copper amalgams, which has been basically, as I said, the latest generation and the last generation of amalgams mainly used on the market. In this situation, we use special procedures. We infiltrate the cracks by using here a three-step etch and rinse system. But what is a little bit different is that we leave quite some time for the primer and the bonding resin to penetrate. Be careful not to have too much light so that the bonding can really penetrate by capillary attraction as well as possible into the cracks. We'll also use here the metal strip to drag bonding inside the proximal contact to seal the cracks from the outside. We use a thin layer of flowable composites to help completing the sealing. It's like a thick layer of IDS. And then we build up the anatomy of the tooth. First, the dentine. You see here the dentine layer can be placed depending on the size of the cavity in 1 or 2 steps. Then a second layer of enamel. I always use a single layer increment of enamel for the occlusal surface. It's all sculpted in 1 step. You see that if you have the right instruments, you can develop beautiful anatomy, and that is the final situation. The cracks from the outside are far less visible than they were initially. And again, literature and clinical experience very positively support this approach. The second type of crack, which is the most critical one, as I said before, is the mesiodistal crack. Whether you have a 1, 2, or 3 surface cavity, the risk is usually the same. The problem with the central crack is that when bacteria can penetrate along the interface with restoration, bacteria are on a highway toward the pulp. The biofilm penetrates straight to the pulp. And the histology, if you look at the article from Ricucci, you will see that you have a very severe inflammatory infiltrate here, which is a response to the penetration of bacteria directly to the pulp. Here, the biological risk and the mechanical risks are much, much higher. If we fail, first failure will be to lose the vitality of the tooth. Second failure will be possibly a vertical root fracture and tooth extraction. My recommendation here, based on biomechanical principles, is to restore the occlusal volume, which is dentine naturally, with a composite material, which has very close properties to natural dentine, and to use a stiffer material for the surface, like bondable high-strength ceramics. That's mainly lithium disilicate, which has, again, mechanical properties, especially in terms of stiffness, which are rather close to natural enamel. The rationale for using ceramics here is due to the fact that ceramics being stiffer, it helps to even more efficiently reduce diverging forces. And diverging forces are the forces which unfortunately trigger progression of the crack and deterioration of the tooth biomechanics. So I found my clinical experience has shown that if you use a stiff material and a good ferrule effect, that might be very efficient in order to stabilize the tooth structure. So that is my recommendation. You see here a patient. Patient came because of, again, here combine pain under pressure and also under thermal stimuli. My first idea was that eventually here that decay could be responsible for the problem, but after doing a proper clinical examination and checking on X-ray or even transillumination, we realized that the extent of the decay is not enough to justify the pain. And conducting some more detailed clinical examination, and every time I have pain under pressure, I'm going to take the fiber optics. And you see here this mesodistal crack. It might be actually one of those teeth with incomplete calcification center fusion. And despite the fact we certainly have severe function, we also have relatively steep anatomy contact. That is a tooth that we need to stabilize if we want to stop the progression of that crack. With an extremely conservative preparation approach. You see that after doing my preparation, we have just two very small spots of dentin exposed. So those are 95% intra-enamel preparation. And on the right-hand side, I'm trying to show you this convex design preparation. The rule here is that we try to minimize actually the concavity on the occlusal surface. And instead of a ferrule effect that will request a little bit more preparation on the facial and the lingual, we basically incline. It's like a very large bevel towards the facial and the lingual. And the rationale behind it is that we create converging forces when the tooth is under occlusal forces. So we try to block out the diverging forces, which are actually the forces creating the problem. We use here the Emax press lithium disilicate, which again has for me the ideal properties in terms of stiffness and anti-diverging effects on the tooth biomechanics. This is finally based on understanding the restorative challenge based on biomechanical considerations, parameters, and trying to evaluate risk factors in a proper way. That will help us choosing the right material and treatment protocol. With us understanding biomechanics, it's very difficult to respond to all challenges encountered in treating pathologies, whether cracked or not cracked. I hope I will be able to welcome some of you to our posterior restoration program that will happen this year, end of October, 22nd to 24th of October 2020. We'll discuss this problem of cracked tooth syndrome in depth. Of course, we'll go even much deeper than what I discussed tonight. We'll also evaluate non-vital tooth configuration, which is another very critical biomechanical situation. And that will be a very interesting program, I trust you would enjoy. So I want to thank you so very much for listening to me tonight. Pleasure to interact with you again for the second Dental Talk 2020, and see you very soon for many more topics. Bye-bye.